Okay, so I think we can get started. Hello, everyone. Thank you very much for joining. I am really pleased to be organizing this joint webinar in partnership with the INHSU Early and Mid-Career Researcher Network and the EUDA. Mette, if you don't mind sharing the slide, I will just introduce the host. So my name is Adelina Artenie. I'm a research fellow at the University of Bristol, and I'm also the chair of the INHSU Early and Mid-Career Researcher Network. And I am organizing today's webinar in partnership with my colleagues, Mette and Tamari. Thanks, Mette. If you don't mind going to the next slide. Can you go to the next slide, please? Perfect. Okay, so I'm very pleased to be organizing this webinar with Mette and Tamari. Mette Kienhorst is a support to practice trainee in the public health sector at the European Union Drugs Agency, and Tamar Mgebrishvili is a PhD student in public health at the Ilias State University in Georgia, and she's also one of the executive committee members of the Early and Mid-Career Researcher Special Interest Group of INHSU. Before I invite Marica to do the opening remarks, I just wanted to say that I'm very pleased that we're organizing this joint webinar because I think we have about 100 people who registered today, and some are familiar with one agency or one network more than the other. But we have quite a lot of shared interest, whether it's research or practice. We're all, I think, interested in improving the health of people who use drugs, and interested in drug use and drug-related research or practice. So you're gonna hear about the EUDA in a minute from our guest speakers, but I just wanted to tell you a little bit about the INHSU EMCR in case you're not familiar with it. So INHSU stands for the International Network of Health on Health and Hepatitis and Substance Users. It's an international network of researchers, policymakers, clinicians, people with lived experience, who share an interest in improving the health of people who use drugs. And INHSU is organizing different kinds of activities from education, knowledge exchange, advocacy, and its flagship event is the annual conference, which just took place in October of this year in Athens. And part of INHSU is the Early and Mid-Career Researcher Network, or the EMCR network, which brings together the more junior researchers. So it's a network that organizes activities by EMCRs for EMCRs. And we organize different events from webinars, workshops, networking events, professional development webinars. So I think Tamari will post a link to the EMCR webpage, INHSU EMCR webpage in the chat. If you're interested in knowing more, feel free to have a look and to get in touch. Just to mention that it's free for students to join and be an INHSU member and an INHSU EMCR member, and there are discounted fees for people who are based in low and middle income countries and people who are community workers. And with that said, it's now my pleasure to invite Marica Ferri to do the opening remarks. Marica is the head of sector support to practice at the UDA. Thank you very much, Marica, whenever you're ready.
Thank you, Adelina. So it is an honor to be here today and to have the opportunity to open this webinar. I would like, first of all, to thank the colleagues at INHSU, Adelina and Brooke, but also to congratulate my colleagues, Mette and Tamar, because they were involved in the organization of the Lisbon Addiction with an amazing amount of work, including Anne Bergenström and Lucas Wissing talking after me. And so finding the time to organize this webinar during the Lisbon Addiction shows what is the attitude my colleagues and I have towards the engagement with the early researchers and the next generation, let's call them like that. So it is a big opportunity for us to increase the collaboration and partnership with other organizations, and also to look forward the full implementation of our new mandate that involves more attention to the younger generation, and more opportunities for collaboration. I'm here opening today. I'm head of a sector that deals with health and social responses, evidence-based dissemination, and as such, we are, for example, responsible for the winter and summer school, and we'll talk about it later. But some of the topics covered in this webinar are also brought ahead by other of our colleagues, the policy analysis and the research. So I hope this is just the beginning of more collaboration to give also space to our colleague to go more in depth on some of these topics. I don't want to take more of the time because there are important issues to be discussed, and I hope there will be also opportunities for the participants to ask some questions. I'm very happy to see friends and colleagues among the participants in the webinar. And once again, good luck and thank you for this opportunity. The floor back to you, Adelina.
Thank you very much, Marica, and really great to have you. So I think Mette will now introduce our guest speakers. Is that right, Mette?
Yes, hi, thank you, Adelina, and thank you especially Marica for opening our first collaborative webinar together with INHSU. As your trainee, it's an honor, of course, to co-chair my first webinar amongst my colleagues, and especially because you were the initiator, Marica, of the EUDA webinar series, which was an initiative started during the COVID pandemic to increase knowledge sharing, discussion, and network building. And that's exactly what we hope to do here today with all of you. So then I would like now to introduce our first speaker and colleague, Anne Bergenstrom. She is our scientific health analyst in the EU4MD project, which is a technical cooperation project implemented by the EUDA in 13 countries in the Southern and Eastern European neighborhood policy area. So please, Anne, the floor is yours.
Thank you very much, Mette, for the introduction. And I would like to start by expressing my thanks to INHSU Early and Mid-Career Researchers Committee for inviting me to speak at today's webinar. And I will now see if I can share my presentation. Can you, 1 second, full screen should be here. Can you, Mette, confirm, please, that it's full screen?
All
yeah?
good. All good.
Okay.
Yeah.
All good.
Okay. So thank you. So in my presentation over the next 10 to 15 minutes, I will touch upon routine drug monitoring methods and briefly on innovative complementary monitoring methods. I will also share information about current call for applications for trainee positions at the European Union Drugs Agency, and briefly about the European Drugs winter and summer schools, which Marica referred to. So, first of all, just a very brief overview of routine drug monitoring and complementary methods. I would first like to reflect briefly on why drug monitoring. Why do we need drug monitoring? So, the main purpose of drug monitoring is to understand the nature and extent of drug problems and to better be able to respond to them. And a very brief snapshot about the types of monitoring and data sources that we consider when we talk about drug monitoring. So here are just some very generic examples. We have prevalence surveys and studies. We have data on drug treatment, data on drug-related deaths, which the acronym we refer to is DRD, and then drug-related infectious diseases such as viral hepatitis and HIV. We also can make use of data on drug seizures and drug law offenses. And then we also want to reflect on why do we need new complementary drug monitoring methods, and I will come back to that. One of the questions that comes up often is whether the drug monitoring is fit for purpose, because there are many challenges in drug monitoring. First of all, there are many gaps in our knowledge. One of these goes back to the reliability of the surveys and response rates. Often people who use drugs may not be exactly aware of what they are using. They may buy a substance, and then actually, if the substance is analyzed, we might come to know that it has been adulterated with other substances. The situation of the drug use, trafficking, sales, and use is evolving rapidly. It keeps on changing over time. It is not static, and the drug market is increasingly globalized. In addition, we know that the drug markets have, in the last few years, been increasingly moving online, and drugs are procured, they're sold and purchased online and through virtual drug markets, including social media apps. And finally, we also know that there are constantly new substances that are being detected. So, focusing now on one of the main methods or approaches used, which we refer to as 5 key epidemiological indicators. The European Union Drugs Agency uses 5 key epi indicators, what we call 5 key Is, to achieve its goal of providing factual, objective, reliable and comparable information on drugs at the European level and the broader European region. These indicators, the 5 key indicators, were developed by the agency in close collaboration with the RATOX network, experts across Europe, and staff from other international organizations that have been working in the drugs field. Just a word about the RATOX. Some of you may not be familiar with the RATOX network. It is the European Union Drugs Agency information network on drugs and drug addiction. The members represent designated national institutions and agencies which are responsible for collecting and reporting on drugs to the European Union Drugs Agency. So this slide shows you the institutional web page about the 5 key epi indicators, and I think Tamar can be sharing the web page reference through the chat. Now, zooming in to the 5 key indicators, the first one is referred to as prevalence and patterns of drug use in the general population, or GPS in short. So obviously, the general population surveys tend to be at national level, not necessarily, but typically they are implemented at national level. They are implemented every few years, not an annual, because it's a time-consuming and resource-consuming type of survey, but they are considered quite representative because they are at national level. Another example of a survey that would provide data towards the GPS indicator is the school surveys. You may have heard of ESPAT, the European project on school surveys on alcohol and illicit substances. This year, a large number of countries in the EU and also some countries in the Eastern European Neighborhood Policy Area implemented the ESPAT. We are namely talking about Ukraine and Georgia. So these are types of surveys that contribute data towards the GPS. The next key indicator is used to be referred to as problem drug use, or is referred to as high-risk drug use. The acronym that we use is PDU. So this, as the title says, this indicator collects and reports data on high-risk drug use. The third indicator is referred to as treatment demand indicator, and the TDI provides information about the absolute total number of people on treatment by substance use, by gender, and also the data on treatment entrance, people who enter treatment for the first time. For each of these 5 key indicators, we have on our institutional website, we have a dedicated page, and there is a protocol. The methodology behind the indicator can be found on our website. So if you're interested, please refer to our website, and you can find, maybe Tamar can share a web link to one of the key indicator websites. All the information is there, including model questionnaires for some of these. The next indicator is referred to as drug-related deaths, TRD. And as you can imagine, so here we are looking at data, mortality, one of the consequences of drug use. And then finally, drug-related infectious diseases, TRID. And here we are really looking at prevalence of HIV, prevalence of viral hepatitis. I would also like to mention that at our agency, we have experts, we have colleagues who are the scientific agents responsible for each of these key indicators, and they organize annual key indicator expert meetings. And so at these meetings, national experts from EU member states and Norway and Turkey come together to review the situation and present new information and data related to these indicators. So this is one of the important processes that takes place on an annual basis by the agency. I'm just trying to keep time. I don't want to go over time. So now at the same time, so the key indicator data is mainly quantitative. At the same time, some areas of drug monitoring do not lend themselves easily to quantification. And it's important to also collect and compile qualitative information. So to complement the quantitative data coming through the reporting by the national focal points against the 5 key indicators, we use workbooks. That's another method or a reporting approach. So the annual, on an annual basis, the national focal points, the RATOX network of national focal points, provide information, qualitative information through using these workbooks on specific topics, which I don't need to read out, they are here on the slide. So we get a lot of qualitative data in addition to the quantitative data coming through the 5 key indicator reporting or reporting on the supply, drug supply indicators. So I mentioned that in addition to the routine data monitoring, there are innovative complementary drug monitoring methods. And on this slide, you have a snapshot of the types of complementary methods that we refer to when we talk about innovative monitoring methods. So data are collected through from hospital accident and emergencies, through wastewater epidemiology. So that looks, for example, wastewater analysis looks at drug residues in communal wastewater through collection and analysis of samples of wastewater from these wastewater plants. Then increasingly, data is being collected from a number of countries looking at syringe residue analysis. So that's another important source of the types of substances that can be detected from drug residue in the syringes. Data is also available from drug checking services and also online web surveys. For example, this year, a large number of countries implemented what is called the European Web Survey on Drugs. Again, we have a lot of information on our webpage. Look out for the results, which will be published in the coming weeks or months, findings from the latest round of data collection as part of the web surveys. These complementary methods have many advantages. They tend to be faster to implement and to provide results compared to, let's say, a nationally representative household survey or school survey that takes months or even more than a year to implement. So these complementary methods have a definite advantage in terms of providing data at a faster speed, to provide a quick picture of what is happening currently. They tend to be at city level rather than at national level. They have advantage in terms of being perhaps easier to implement, and they are certainly less expensive than nationally representative samples or surveys. And they tend to, they also offer the advantage of focusing on specific groups of people who use drugs. For example, the web surveys are targeted at people who actually use drugs. So, and ultimately, the data coming from these surveys can be triangulated. And that's an important way of having a full comprehensive picture of what is happening, what is the nature and extent of drug use, because each data source has its advantages and its weaknesses. So one of the best ways to build confidence in having a comprehensive picture about the extent and nature of drug use is to use a mosaic, what we call mosaic approach, by triangulating one data source against another in order to have a full picture of what is going on in a specific country or region of a country. So ultimately, all the data feed into what is called the statistical bulletin. And here is the, well, it's a screenshot of our institutional webpage about the statistical bulletin, where you can look at, you can go and explore data that are available at national level and also city level data, you know, from those complementary drug monitoring methods on the right-hand side. I think, do I have another 5 minutes or time? Yeah, very briefly. So to summarize, core routine monitoring data is primarily national data, and complementary monitoring tends to be at subnational level and target drug use in specific populations. All data collection methods have their strengths and weaknesses, and ultimately one of the best ways is to triangulate information from multiple data sources. We also monitor responses, and just very briefly, you can see that EUDA collects data on coverage of needle and syringe program as an example, and coverage of opioid agonist maintenance treatment across the EU, based on the recommended interventions. And on the right-hand side, you can see some recent guidance that has been published by the agency jointly with ECDC. So we have another stream of monitoring is looking at the responses and availability of interventions and the coverage of interventions. Now, moving on to the second and last part of my presentation, there are multiple opportunities for early to mid-career researchers and other drug professionals interested in being closely engaged with our agency. There are currently up to 11 trainee positions at the agency. They are in different units, public health unit, and many other units. So I think my slides are moving by themselves. So just going back. So there are 11 opportunities. The deadline for applications is coming very soon. The deadline closes on 11th of November. So if you're interested in working at the EUDA as a trainee, please look at those individual announcements and apply for what you're interested in. I would like to give one example of a trainee position that is currently open for applications in the EU for Monitoring Drugs project, which I'm part of. So last year, or actually earlier this year, we had Tamari, who is part of this webinar. She was the first EU for MD project trainee, and now we're open for applications for the next trainee to join the team for a few months next year, 3 to 6 months. The other traineeships are up to 9 months. The EU for MD is for the duration of 3 to 6 months. And finally, my last slide, the European Drugs Winter and Summer Schools, which Marica referred to, is coming up. And Tamari will post in the chat the application deadlines. And the EU for MD project also offers a couple of bursaries that can be, there is a separate deadline for those, and Tamari will post it in the chat. So thank you, Tamari. And we are looking forward to large numbers of applications to both the trainee positions as well as the European Drugs and Winter and Summer Schools. The theme of the winter school is on crime prevention, and the special theme of the summer school next summer is on synthetic opioids. So exciting program as always. Please do apply. And thank you very much. And I apologize if I went over time. Thank you.
Thank you so much, Anne. This was a very insightful presentation about your work and about our agency. And I would like as well to stress that this webinar, like you explained, is a direct result of the fact that we had Tamari as an intern here together with us here in the trainee office. So I'm happy we realized this. So our next speaker is going to be Lucas Wiesing, another sector colleague of us who is already working almost since the beginning for the then EU EMCDDA, now EUDA, since 1996. Lucas is an epidemiologist, and he set up and developed data collection systems for infectious diseases, problem drug use, and mainly harm reduction coverage indicators, which have been adopted globally. And currently, he would really like to tell us all about his Optimus project, which is a working group of international experts on opioid agonist maintenance treatment. So, Lucas, please, the floor is yours.
Thank you very much, Mette. Can you confirm that you hear me well?
Yes, we do.
And my screen is hopefully visible. So thank you very much first to Mette, Tamari, and Adelina, and INHSU in general for inviting us and me. It's really an honor. I will try to give you an example of the work that was so well presented by Anne in the previous presentation. So where Anne gave the broad overview of many of her systems, I will talk about a project that I've been working on in the last few years more closely, which is the Optimus International Consensus towards evidence-based and patient-centered care, but it's basically around outcomes of opiate agonist maintenance treatment. We have currently over 100 collaborators, and they're growing since the conference. So I want to stress that this is what I'm presenting is the work of many, many people, and I'm extremely thankful for all the support we have had, including many colleagues, several colleagues from inside the EUDA. So this is a very collaborative project, and this is basically what the EUDA work is about. I'm having a problem in moving to the next slide. Okay. So this is the number of names that you can see here on the Optimus study, and the acronym Optimus sounds nice, and it does make sense, although I can never remember exactly how it is composed, but it's something about medication treatment and opiate treatment. It works actually, but I'll show you somewhere else. So a few years ago with Marica, we were discussing what we should do next, and we were aware that we needed to know more about treatment, and in particular opioid disorder treatment, specifically because we do have, as Anne presented, the treatment demand indicator, which gives a cross-sectional view on people entering treatment, but we don't know what's happening during treatment and after treatment. And obviously, why we chose opioid disorder treatment is also because opioid use is the main driver of drug-related disease and death globally. As we all know, around 3/4 of all drug-related disability-adjusted life years lost are due to opioid use disorder. And opioid agonist maintenance treatment is highly effective at reducing health problems and mortality. We commissioned and collaborated with a quite brilliant Spanish group led by Luis Sordo and published a systematic literature review on the mortality comparing people who use opioids inside and outside opioid agonist maintenance treatment. And the result was about a 3 to 5 times lower mortality inside OMT than outside. And this result has been confirmed by many other reviews and studies. And just to mention that it's not only on mortality, but an older study by Mette et al. In 1993 found also a 6 times lower HIV incidence in OMT than not in OMT. So basically, it's not really dependent on the outcome. OMT really reduces risk quite massively. So you would expect that OMT outcomes monitoring, and outcomes monitoring basically looking at what happens with a patient during the OMT or the treatment course, like does the patient improve? What measures do you use for that? These measures should probably prominently include public health indicators such as HIV, Hep C infection risk behaviors, overdose. And we did a systematic review including observational treatment outcome studies. We found 27 studies. I will not bother you now with all the methods of that, but we followed the standard guidelines. And we found 2 main results. Basically, that there was no agreement. We found a large variation in outcome domains and indicators. And we could, across the studies, identify sort of 8 common domains, but only 2 of those were used by more than half of the 27 studies. I'll show you in a graph. And also we found that few studies included key public health problems as part of the patient's outcome evaluation, such as I mentioned already, non-fatal overdose, infectious diseases, injecting, and sexual risk. So this is the graph showing you how the 8 domains that we identified in the 27 studies, which were drugs, so substance use, crime, health, the treatment domain, which includes, for example, variables such as retention, social outcome, harms, death, and even 2 studies looking at economic evaluation. Only 2 of these, and not surprisingly, the substance use domain and the treatment domain, were used by more than half of the studies. And actually, if you would look at the indicators used within these domains and the variables, the exact variables and the formats, they were all over the place. So we concluded there was no agreement and a lot of variability. And what I also I didn't say yet is that basically we found a sort of time gradient where the older studies were very much focused on abstinence and only on substance use outcomes, whereas the more modern studies were already having this broader view with the domains I'm showing here. So what are the consequences? So key health consequences of opioid use disorder were also infrequently measured. Only 2 out of the 27 studies included HIV or hepatitis C virus, and 7 out of the 27 included injection drug use among the reported treatment outcomes. And harms were reported by 8 out of 27 studies, with needle sharing reported by 5, sexual risk behavior by 4, and overdose by 5 out of the 27 studies. So the implications, as already said, observational opioid treatment outcome studies frequently fail to report on main public health impact of opioid problems. This is despite strong evidence on the public health effect of opioid agonist maintenance treatment in terms of reducing mortality, infectious disease, risk behavior, etc. And there was obviously a need to agree on a minimum set of outcome indicators on the health or public health impact of opioid agonist maintenance treatment in Europe and actually globally. So we started a project to develop this consensus guidance for OMT outcomes monitoring with agreed indicators, methods to monitor OMT outcomes. It was aimed at including key public health consequences of opioid use, such as infectious disease and overdose mortality, and basically to have a public health perspective on treatment outcomes. We started with workshops, as we often do at the EUDA. The first one was actually with experts of the treatment demand indicator from 17 countries. And we confirmed in that workshop that those countries that were participating also had no common approach to treatment outcomes monitoring. So this was the confirmation of what we found in the literature review. Then we formed an expert group and had a 2-day meeting early in 2019 with 20 people. Now we have 116 people, experts, including people with lived experience from 32 countries. We had to first define what we meant with opioid agonist maintenance treatment. You can imagine if you have 20 people in a room and try to discuss what outcomes, then people say, but what are we actually talking about? So basically, we agreed to sort of define what is best practice around opioid maintenance treatment, and this resulted in a set of principles, which we now call the 10 key principles of effective opioid agonist maintenance treatment, which are in our guidance as well. So this is a bit of a side result of the project to define outcomes. And well, these are the things that you are well aware of, I assume. So about, having good access to treatment, to having access for different vulnerable groups, avoiding stigma, following the WHO recommendations on dosage and clinical aspects, etc. So we then mainly drafted outcome domains and indicators in the workshop in both meetings, and we also decided about the format of the guidance and what to do for the further development. And we decided that 20 people in one room was not enough to give credibility to this work. So we decided to set up a Delphi study. And the Delphi study is basically where you set up a panel and you ask the panel to agree or to provide their agreement or disagreement with the different, with your scale or with your indicators. So we recruited a wider panel for the Delphi consensus study during 2020 to 2022, where we asked the experts collaborating, which were by that time already many more than 20, to recruit these panel members in their countries. We finalized Optimus guidance already by 2022. After the first round, I will give you the methods in the next slide, but after the first round of the Delphi study, we finalized the Delphi study this year, and we have now feasibility testing ongoing. Excuse me. We have now feasibility testing ongoing. And just to make clear that feasibility testing is really different than the Delphi study, where in the Delphi study, we asked the panel if they agreed with the certain questions and indicators, but the feasibility testing is using the resulting questionnaire with the outcome indicators in clinical practice and testing what the experiences are. Okay. So these are the methods. We defined the domains and indicators. We defined questions to measure those indicators. And this was formatted as an outcomes questionnaire that should be able to be used in a clinical session directly. We translated, importantly, in the national language, which was an enormous work. And we used back translation as a quality check. So the Delphi study had online surveys inside the EU survey platform, asking the panelists to evaluate each outcome question on a 6-point scale from strongly disagree to strongly agree. We had 2 panel survey rounds, as I already mentioned. We reduced basically because the amount of work was gigantic with so many countries involved. And because we already found a quite high consensus on the first round. We gave the possibility to give open comments for every outcome question. And we aimed at having 18 to 20 panel members per country, half of them professionals and half of them service users. And we were targeting a 50-50 gender balance in both groups. So these are the 6 domains that were agreed in the workshops. These are treatment, physical health and risks, mental health, social functioning, substance use, and quality of life. And here you see the breakdown in indicators. So we have 13 indicators, 2 among treatment, which is treatment continuity, treatment satisfaction. We have 5 under physical health and risks, physical health, overdose, injecting drugs, sharing, disease testing. We have 1 on mental health. We have 3 on social functioning, including 1 on legal problems. And we avoided to ask the service user about crime because this can be very stigmatizing. So social support, social activities, and legal problems. And we have 1 on substance use, which is very detailed, where the interviewer can actually pick all the different substances and also the frequency of use. And we have a quality of life indicator. So the results of the Delphi study were that we managed to get 757 panelists from 29 countries over the 2 survey rounds, of which 46% were service users and 40% female. We're quite proud of, especially of the high percentage of service users that were in the panel, almost the 50% we were targeting. We managed to translate into 19 languages, both the surveys and the resulting outcomes questionnaire. We found strong support for domains and indicators with an average score in round 2 across all indicators of 5.2 out of 6, and a small increase between round 1 and 2. We almost received 1,500 open comments in round 1, which we all evaluated and were followed, or evaluated and incorporated if agreed. And these mainly suggested the need for more detailed questions. So apart from the questions that I showed you in the previous slide, we also made optional questions for the same domains and indicators so that the clinician can actually go in more detail if this is necessary. So we developed an outcomes questionnaire aimed at being directly usable in OMT services and exclusively based on service user reported indicators. So the feasibility testing has only just started, so we have only very limited results. We have 20 service users from 4 countries, and actually at the conference in our side event, more results were presented, but I didn't have them yet, so I couldn't include them in the slide. Interview time seems manageable with about 14 minutes average interview time for the questionnaire if one sticks to the 4 questions, and around double that if the clinician and patient decide to use some of or many of the optional questions. And the idea is that the 4 questions are sort of screening instrument where the clinician can actually find there is a problem in a certain domain. And then if there is time, they can have these optional questions to further detail the issues. The questionnaire seems well accepted by both service provider and service user. Some comments were that it's balanced, feasible, and very useful. And one user said, I've never been asked these questions before in a positive way. And further feasibility testing is ongoing. So in summary, we found there is a need for an international consensus on opioid disorder treatment outcomes, domains, indicators, methods. Outcomes need to be public health relevant and cover key health consequences of opioid use disorder. The Optimus consensus questionnaire covers 6 domains: treatment, physical health, mental health, social functioning, substance use, quality of life, and is available in 19 languages. It aims at providing a structured set of outcomes, enabling a conversation between service provider and service user in order to monitor treatment results over time. In addition, our group formulated a set of 10 key principles aimed at lowering barriers and increasing access to OMT and OMT coverage among people who need OMT. Our Delphi study showed strong support for the outcomes questionnaire with a mean score of 5.2 out of 6 from a large panel of professionals and service users, and almost half of them being service users from 29 countries, in which 40% were female. Feasibility testing of the outcomes questionnaire is ongoing with promising first results. Highly positive feedback from both service users and service providers. I must say that at the side event, at the conference, we did get a country that mentioned that actually their interview times were much longer than as reported from the other countries, so we have to look into that. Optimus is the first OMT outcomes monitoring guidance based on expert consensus from a large number of countries, developed together with a large number of service providers and service users with the aim to save and improve the lives of people with opioid use disorder. And just, if I still have time, one slide on a question that I was asked to address. And that Anne already quite well covered, but I have here a few points summarizing, I think, how Optimus, this project and the other projects already presented by Anne, work in informing policy and practice across Europe and maybe beyond. So I just presented Optimus as an example of standards development and consensus building around best practice in OMT. We have experts from 32 countries and more are joining. EUDA has always worked this way by bringing together the best experts from the collaborating countries and agreeing on common approaches in close collaboration with the RATOX network of national focal points, which Anne already mentioned. So projects often start developmental, including scientific studies and publications, and if successful are integrated into formally agreed monitoring systems with the EU and other EUDA collaborating countries. For example, the 5 key indicators and other data collection systems like harm reduction coverage discussed in the previous presentation, and which are actually led by other sectors in the EUDA than our sector on health responses, health and social response. By comparing countries' performance using robust and agreed methods and publishing comparable and reliable data in our annual EDR, European Drug Report, there's a strong peer pressure on all countries to reach the agreed standards. And I think this is one of the key issues on how EUDA has worked, and so that also to build the support for our work is by actually doing it together with the collaborating countries and involving as many parties and stakeholders as possible. This is just an example already shown on a slide by Anne, but you see here the coverage of opiate agonist maintenance treatment across the EU as estimated by dividing the number known in treatment in a given calendar year by the estimated number of people who use opiates in the countries. And as you can see, there is quite big variation between countries. There is the WHO target of 40%, and actually the EU average across our collaborating countries is 50%. But you see that several countries are reaching very high levels and others are not. So this sort of indicators provides a very strong tool to try to improve standards and data across the EU. Thank you very much. And I give the floor back to Mette, I guess.
Thank you, Lucas. I think now we'll proceed with our questions from the audience and our discussion. Please, Adelina.
Thank you. Thank you very much, Lucas and Anne. That was a really great overview, the broader level overview given by Anne, and then talking about a specific project by Lucas, which is really interesting and I think impressive to try and get countries to agree on indicators for OAT outcomes. So we have 2 or 3 minutes for questions, and then I would like, so there are some questions in the chat about the trainee opportunities and how to apply. So Marica will be able to address them at the end in the closing remarks. Maybe we can bring up one of the questions, Mette, that we had prepared, if one of the speakers can try and answer in 2 minutes, and then we'll just pass it to Marica.
Okay.
So one of the questions, I mean, I think you touched on this, Lucas, a little bit, and this is for Anne or Lucas, you're welcome to speak to it. Why do you think it's important to have a region-wide agency that guides the monitoring for these drug-related outcomes rather than country-specific? For example, how has it improved collection of data and measurement of key outcomes compared to other regions of the world? And Lucas, Anne, if you could give us an answer in 2 minutes, please.
Lucas, can I go first?
Yeah, go first. Please.
As I work in a regional multi-country project, I love this question, frankly. I think it's, of course, it's a bit of a cliche to say, but I think it's true if we say that drugs know no borders. So, I mean, for obvious reasons, drugs move across the borders. And if we look at, we work in the European Union Drugs Agency, but I think we are surrounded by countries in the European neighborhood. So whatever happens in the neighborhood affects Europe and vice versa. So I think one of the exciting things that, for example, the EU4MD project, which is EUDA's international technical cooperation project, has managed to do in the last couple of years is to introduce established drug monitoring methods and tools and share them and make them available to countries in the European neighborhood policy area. So the lessons learned and the tools and the methods, the survey tools and the methods have been shared with the national drug observatories or staff working in drug monitoring in the neighboring countries such as Georgia, Ukraine, Moldova, which are now candidate countries to the European Union. And that point brings me to my last point. It's not only important, but it's actually essential for the candidate countries to the EU to start collecting and reporting data on all aspects of the drugs phenomena to EUDA, because one of the criteria of the EU acquis is for the candidate countries to have a operational functional national drug observatory, such as the national focal points in the EU. So the candidate countries need to have a functional NDO, and they need to have operational drug monitoring information systems. And that's why it's essential now for us to facilitate sharing of this knowledge and tools and methods. Anyway, I'll stop there and pass over to Lucas for his reflections.
Thank you, Anne. Yeah, I think you summarized it very well. So I don't need to say much. I think also in my last slide, I answered this question partly. So that basically by having data and agreeing methods across countries, you can compare, you can improve. I think everything works like that in science and in public health. You try to collaborate across borders because knowledge also doesn't have borders, just like drugs don't have borders. And like, for example, in the EU, if there is the idea to have common policies on crime and drugs and other problems, you need to have comparable data. So I remember when I started at the EUDA that there were huge discussions between some countries on completely different approaches to drug policy and drug interventions. And as soon as the EUDA started publishing the data and showing evidence, these discussions disappeared. There was suddenly an incredible movement towards consensus on how to do it and what works best. And this is what we're now seeing in Europe, that the countries collaborating with the UDA have a very common approach to things. And we are also at the global level in the UN with our colleagues from with the countries and the EU representing or leading sometimes the discussions at the global level, because we are united and we have actually found best practice to work in our region, and then other regions may copy that.
Thank you very much, Lucas. I think both of you gave great answers. I think, unfortunately, I'm not going to be able to take additional questions because we have only a few minutes. I just want to thank both of you for coming on today and giving such a great presentation, an introduction to how drug monitoring and policy works at EUDA. I just want to give a few minutes to Marica, if she is, yes, she's on, to address some of the trainee questions that were in the chat. And Marica, if you'd like to also do the closing remarks. Thank you.
Yes, thank you very much. And thank you for my colleagues for their presentations. And echoing what has already been said by them, the value of the European Union is that we have a drug strategy that shows the line of the different countries that are autonomous in their decision, but still look in the same direction. And our agency is lucky to be in this context. Talking about the requests on our training, they can find all the rules for application and access to the bursaries and scholarship in the link that was shared. We organized the schools in collaboration with a Lisbon-based university, the ISCTE, and they have, so beyond the bursaries that are offered by the international cooperation projects, there are also bursaries offered by the university. There are some criteria to fulfill, so look at them. And I also mentioned the fact that we have ceilings to the number of participants we can accept. This is because experience told us that if we go over a certain number of students, that is 60 for the face-to-face edition in Lisbon, and I don't frankly remember now, I think 25 or 30 for the online version. We don't manage to have the working groups, and especially for the face-to-face editions, this complicated a lot the visits we do to the services. You know, we visit the services during the working time to make sure we are aware of all the situations and we can talk with people working them, but we cannot invade this space with too many people. So the recommendation is to try to apply as early as possible. Criteria for the international cooperation bursaries: you need to write a motivation letter that is considered by our colleague to make sure that the participation in the school has then a cascade effect on the country. For the normal students, again, you write your reasons, and we try to do the best to accommodate a higher number of people. We are very happy because we have a huge variety of professional backgrounds, country of origins. We are really engaging with the worldwide participation. This is very important because it's also an opportunity to learn together what are the specificities of the European Union environment. And we have several cases of students that got back to their country trying to implement some of the experience that they learned during our schools. I think I answered the questions that were in the chat. If I didn't, please contact us. Our address are the same for all of us: name, family name, at uda.europa.eu. Closing remarks. Once again, thanking our colleagues at INHSU for this opportunity. We hope there will be more. It's very important for our environment to take care of the next generation of researchers and interest people. We are observing a kind of passage in this moment, even in our agency. Some of the pillars of this environment are retiring. So we need to look forward to the next generation. We need to make sure brilliant and motivated people is attracted to this field. That we don't hide is sometimes frustrating because the changes takes a lot of time. There is a lot of policy and ideology that we need to accommodate while building the evidence for actions. So I really welcome and I'm thankful for the synergies with organization to attract brilliant researchers into our field and to build together a brighter future for our environment. So with this, I would really thank you all. And yes, contact us if we didn't address all the questions.